Welcome to the Dose of Optimism, where I talk to the optimists in healthcare. My name is Omkar Kulkarni, and I work at one of the world's best children's hospitals, where I lead innovation. I started KidsX, which is a premier international startup accelerator for pediatric innovation. And over the years, I've met thousands of startups, investors, and innovators. Every one of them has a story, and every one of them is optimistic about the problems they're solving. On this podcast, you'll meet amazing people who will share their stories and what makes them optimistic about the future of healthcare. A little note before you get into this episode. This podcast is for informational purposes only. We are not offering medical advice, and we're not endorsing any products. Please talk to your own physician about your health or the health of your children. All right, let's get started. First up on our episode is Dr. Joe Corkery and Julie Wilner. They're both the co-founders of a company called Jaide Health, and we're going to talk to them about the importance of language translation, both written and verbal, as it relates to healthcare delivery.
Jaide is a platform that we built to provide AI-driven interpretation and translation services for patients with limited English proficiency. We built this, really to address a lot of the existing gaps in the provision of equitable language access for patients, and to really help to provide better outcomes for patients who don't have strong English proficiency.
Simply put, you can think of us as a HIPAA-compliant Google Translate for hospitals.
So why can't hospitals just use Google Translate?
So there are a couple reasons for that. I think the first and biggest and most important reason for that is that Google Translate is a consumer-facing AI offering, and therefore can't provide the compliance, security, and privacy guarantees that are really expected when you're handling healthcare-specific data. The second answer to that is that it is a consumer-facing offering and really has not been enriched specifically for healthcare-specific content as well. And the third aspect of this is that as a consumer offering, it's not integrated into clinical workflows. It's not something that you can easily use within the clinical context. And it's not something healthcare organizations can customize specific to their own needs, their organizational preferences, as well as their patient population or their desires there as well.
I think that's an important distinction, right? I think having Google Translate is a great tool for so many different use cases, but for medical terminology, where you really have to make sure that you get information communicated accurately to people in their native language, you really want to make sure the models are rightly tuned for medical terminology. So it makes total sense. So I remember meeting you both, it was years ago, and you were starting to build this concept. And Joe, you've got this background both from medicine and, of course, as a technologist. And Julie, you're a nurse. You've worked in nursing operations. How did your different perspectives on healthcare and technology help shape the product that you ultimately built?
Yeah, that's a great question. I think ultimately, coming from both of our combined backgrounds, it was really important to us that we were going to build a product that solved a meaningful problem for both patients and providers. And to do that, not in theory, but in actual practice. And so, what that really focused us on is really, in order to do that and to deliver that solution, that's something we decided to focus really heavily on the workflow and the integration aspects of that.
Yeah, it's all about workflow. Configuring workflow and meeting users where they are is the difference between your tool getting used and making an impact and your launch being a complete failure. We know that the best technology doesn't always win every day in medicine, and that the best product is the one that gets the job done and doesn't disrupt the existing workflow. Most workflows and most tools are really designed with physician throughput in mind, but hospitals are run by nurses. And very few workflows, very few tools are designed for nurses by nurses, or for that matter, for interpreters, who are a lot of our end users. We build for all of them and with all of them in mind. I've spent almost more of my career in tech than in nursing.
That's the best
So
than nurse, by the way, Julie, a techie nurse. Just for LinkedIn out there, techie nurse is the
Techie nurse. Okay, I've got to
tagline of the
update
book.
that profile. So while I say yes, I'm the nurse at the table, I try not to be the only nurse at the table. I'm not the clinical expert, but I am there making sure that we have the right clinical input and that we have that nursing perspective from day one. So Honestly, during our intro call where we're trying to pitch a product, I'm sitting there saying, "Will you bring me a physician champion? Will you bring me a nursing champion? Who's your nurse manager?" We want people that understand that workflow throughout the design, the implementation, the training. Otherwise, it's not going to work for them.
You think about workflow, having worked in healthcare for both of you, one of the biggest disruptions to a healthcare workflow is when a provider meets a family that has a language that is not English, that's their preferred language. And the provider wants to be able to communicate with that family, but because of the language barrier, it creates a disruption. And so, how do you think about how your tool, whether it's translating or interpreting, and maybe you can remind us the difference, but how do you think about how it integrates into that workflow in a positive way?
So just, in terms of like, clarifying the difference between interpreting and translating is typically interpretation refers to spoken translation. And when people say translation, they're usually referring to written translation. And I think what you're right is in these situations where you have patients and families and language is a barrier there, it's really important that the clinicians have all the right tools at the right time for those different types of interactions. And, for a lot of those complicated conversations with the patient and with the family, being able to bring in, a human interpreter to facilitate that conversation is critically important. But at the same time, there are often lots of small, simple conversations that need to happen with the family or with the patient, whether it's wayfinding or scheduling or just a quick check in about would you like lunch, that could actually be facilitated using an AI based interpreter as well. But I think more importantly, and I think this is an area where there's a really big opportunity right now, is that the documentation that patients go home with and documentation that they receive more in most organizations is not actually translated into the patient or the family's preferred language. Usually what happens is, an interpreter will come in and do a site translation of that for the patient and the family, but it relies on them to take notes or to remember that. And I think most people, anybody who's ever been discharged from a hospital knows that you don't really remember what was told to you during the discharge process. And so having that written documentation in their preferred language is critical in terms of making sure that they understand what they're supposed to do after the visit, when they go home, knowing when to come back and when they don't need to. And so I think that's an area where I'm really excited about the expanding opportunity and potential to leverage AI to address a lot of those language barriers. And then I think similarly, being able to have access to both AI and humans for a lot of those in person conversations.
These days, I'm hearing a lot of pitches from AI companies. It feels like they're trying to find a use case for this AI that's out there. I really believe that it's important to start with a problem. When you built this, did you have the problem in mind, or were you just looking for, use cases for AI?
Yeah. So, I mean, this was like a fortuitous combo of both in the sense that, during our time at Google, we spent a lot of time talking to healthcare executives. And one of the most common requests that we received was, can you make Google Translate work for healthcare? And so when we left Google, this was something that we saw was still an opportunity. This was still a problem that needed to be addressed. And at that same time, the large language models had really just begun to come on scene. They were rapidly advancing in pace and capability. And we looked at this and it's like, oh, wait, this is a perfect solution to this known problem that we have here. And at the rate it was going, we could see that there was going to be a point in the very near future where this was going to be, sort of a no-brainer solution to this problem. And so we wanted to get ahead of that and start building for that future. So we absolutely were deeply familiar with the problem from our time at Google. And I think we both experienced it during our time in clinical work as well. I remember taking a class in medical Spanish a long time ago as well. But it was definitely a problem that we knew we needed addressing. And it happened to be available at a time when there was a solution that was well suited to solve it.
Are there specific patient populations or care settings now that you're actually live and in use around the country where you've seen a really big impact so far, like emergency rooms, outpatient care clinics, discharge planning? Are there specific areas where this is making a big impact?
The answer to that actually isn't what you would expect. We have seen the most usage from hospitals that have a language services department or that have interpreters on staff. Because particularly the translation, the written component, that's something that takes them the most time to do. It's incredibly time consuming to sit down at a computer and translate one document from one language to another. AI really is an extension of them. It helps them do that so much faster and enables them to provide more documentation to patients than they could before while saving a tremendous amount of time. So, like at Children's Hospital Los Angeles, it used to take them 90 plus minutes to write out a discharge summary. Now it takes one of their language service members about 5 minutes to review, make edits, and then they can do that all from the unit. They don't have to go back to their office. They can hand it back to the patient. So we're able to do that scale anywhere where there are interpreters on staff, or we have been at Jade as a startup. Now that we're part of AMN Healthcare, we're going to be able to actually start including hospitals that don't have that expertise on staff, and AMN can provide the interpretation and the review of those documents. We've been live at Children's Hospital Los Angeles, transforming their discharge process, as well as Cambridge Health Alliance, both fairly unique in that they have those large language services staff members.
I mean, I think we see that in a lot of use cases, right? That AI is initially showing a lot of value with helping people just do their work much more efficiently and quickly. And then after it's proven in that setting, then starts moving into settings where perhaps that resource isn't even available or that expertise isn't available. And I think you're saying the same thing. So that's for translation. Let's talk about interpretation. So where is interpretation in your mind already showing, maybe even outperforming the traditional interpretation approach versus where is the traditional human interpreter essential? Where are you seeing that play out in the AI space?
So I think our goal with this really is to enable the existing cohort of interpreters today to operate at the top of their license. There are many scenarios in which patients need an interpreter. For a patient who has limited English proficiency, they're going to interact with people throughout their healthcare journey. And oftentimes it's difficult to get a human interpreter as part of that process, often during check-in, wayfinding the hospital, a lot of those administrative type conversations. Similarly, when you're just having short, brief interactions. So there are a lot of spontaneous interactions that happen in a clinical setting that are not, these deep clinical conversations, but they're touch points that have to happen. And normally you go in, you ask a question, it's, maybe just a minute or two. Those conversations, often don't happen when you have to bring in a third party to facilitate that conversation, just because it takes maybe a minute to go find the device, you've got a couple seconds to wait, and so those times are really quite fast, but it's a little bit of an overhead, which causes people to just not have those conversations. And so I think where we're seeing a lot of value right now is in those brief spontaneous conversations that people are having, as well as more of the administrative routine operations, as how do you navigate the hospital, how do you check in, how do you check out. But we still see a huge opportunity for the human interpreters to facilitate those complex conversations with patients as well as families. I think family meetings and long-term planning are incredibly valuable in those scenarios.
I'm fascinated to see how the AirPods do. Maybe not with medical language, but
Mhm.
even just the day-to-day navigating. At our hospital in Los Angeles, we've got a large number of patients whose primary language is not English. And it would be fascinating if 5 years from now, people were walking around with AirPods and they could understand what was being said to them in a way that made sense to them, even if it's wayfinding and basic things. But just, if everybody had their own interpreter in their ear, it's just an interesting world as you think about language equity and things like that. So let's talk about misconceptions. Where do you think the misconceptions are right now in 2026 about AI translation and interpretation? What are people
I
getting
think
wrong?
I think probably the biggest misconception out there, especially among healthcare executives, is that people aren't already using AI as part of their work. Clinicians regularly turn to AI when they can't get the resources they need. And if, they're not provided by the institution, they will go look for the resources that they have available to them. And so I think this is something that it's really important that healthcare executives actually need to understand and get ahead of that so that they can actually use compliance solutions that solve the problem that they have and to do it at scale. And so I really think it's this a lack of awareness that not that AI isn't ready, it's that people are already using it, but there are better ways to use it and more compliant ways to use it as well.
Joe and Julie, I've got a question for you. You've been incredibly successful in building this product, one of the first to market. You've been getting hospitals to purchase it, use it, lots of great data out there. And then I saw that you sold it. Why'd you sell Jade Health?
We had so much fun coming out of Google, coming out of a big company, and starting our own, solving a need. As techie clinicians, we love using technology the right way to make lives better for patients and clinicians and for the business. It's kind of the trifecta, the win win win. That's always what we want to do. And we were able to do that. We were able to launch at a handful of hospitals, and we were ready to grow. As a techie clinician, you want people to be using your product. And it was getting harder to grow without a sales force and without the human linguists that were there to pair with us, whether that's for the review of translations or to be able to hand off a conversation to a human on the interpretation side. When we started looking at next round of funding, we also started talking to strategic partnerships, and we'd been talking to AMN Healthcare really since the beginning. And it was just kind of one of those better together stories where everything that we were going to need to build out in our next round of funding, they already had. And we've been there since June, so a few months. And it's been really fun to be able to continue to build with kind of the power of the brand, the team, the sales force behind us, and to be able to work with this huge pool of linguists to help guide our growth.
Do you all speak the different languages?
I speak tourist Spanish. I did a little bit of medical Spanish when I was in medical school. I'm by no means fluent.
I've got some high school Spanish and French.
You feel the pain as people who've practiced and been in the medical delivery space. If English is the language you prefer to speak and your main language, I imagine when you interacted with patients who spoke other languages, you perhaps felt that pain personally, which may have perhaps inspired you to build the company.
Yeah, I mean, I certainly felt it a lot, and I remember there were many times where there were patients, who I think Cantonese was one of the languages where we actually had a lot of trouble getting interpreters for. Now, this was like back in like 2003 or something like that. Like before, there was a lot of, both phone and video based interpreting. So we relied heavily on in-person interpretation. And I remember it was a real challenge to take care of those patients because you really couldn't see them or interact with them without an interpreter. And so I think it's been a great advance to see both the addition of phone and video based interpreting. And I think AI will just continue to complement that.
And there is some regulatory push behind this too, right? In this part of the ACA, there is a requirement to a certain degree for written materials that are provided to patients to be in a language that is their preference. And so, as that is enforced and as that becomes fully implemented, the need for technology like this, I think, becomes not only important from a clinical standpoint, but also perhaps regulatorily required.
Yeah, I think the reality is ultimately you're going to need AI to provide those translations at the scale that you actually need to deliver. And that's why, again, I think as Julie was talking about, coming together with AMN allows us to use AI to accelerate the work that humans are doing to generate those translations and to do them at a larger scale. So being part of AMN allows us to offer that speed to organizations that can't provide that in-house.
Congratulations on what you built and for your recent acquisition, and looking forward to all the great work that you'll continue to do. Thanks for coming on the show.
And now a thank you to our generous sponsors.
Healthcare doesn't need more disconnected AI tools. It needs one clinical AI layer clinicians can trust and that health systems can scale. Nabla brings together ambient documentation, dictation, coding, and workflow support into one seamless experience. Learn more at nabla.com. My next guest is Nikhil Krishnan. Nikhil, if you are familiar with his Out of Pocket work, which is a great newsletter that he puts out regularly, along with a whole host of content and information focused on healthcare innovation. He's got a really great pulse as to where things are going as it relates to healthcare and innovation and technology. And so I enjoyed this conversation a ton as we dove into various topics around artificial intelligence, pediatrics, care model innovation, cash pay, all sorts of interesting things. I hope you'll enjoy this interview with Nick Hill. As you think about pediatrics and the space today, whether on the provider side or the payer side, or even more the startup side that's focused on pediatric oriented tech, what are your initial reactions?
I think it's definitely an area where especially non-healthcare people tend to gravitate to, right? Helping kids obviously always is like a
Yeah.
feel good thing, right? But building a business there is very different, as you know more than anyone. Like pediatrics is not exactly the most well-funded specialty out there. There's not a ton of wiggle room for when it comes to buying tech or all that kind of stuff. I think there's some tension there. That being said, I do think that for better or worse, pediatrics is an area where the parents are very engaged. Like it is a very engaged patient journey, like much more so than a lot of other areas, especially in specific windows where kid is just born and all that kind of stuff. And so, you really can provide like a very differentiated consumer experience along those lines if that can meet a lot of that demand and engage patients in new ways. As an example, I live in New York. Tribeca Pediatrics is like very popular out here. And, one of the things that they did that I think helped them stand out in a lot of ways is one, they sort of have a bunch of locations. So it's easy to bop around to different ones and they have context of who you are when you go to the different ones. And also, two, they sort of focused on timeliness of appointments so that you can see someone relatively quickly if you need to. It might not be your provider every single time, but you can see someone. I do think that there's just like different ways that you can approach the pediatrics business model because it's such an engaged base with who all care about very different things too. So you can pick different slices. Am I rabbit hole of being on the internet a little too much? I follow a few direct primary care practices that focus on pediatrics. And it is interesting just to see how they present their what's valuable about the services they offer. It's like very different in a lot of ways, right? Some people, for example, are focus on kids with specific needs and they have like a very strong opinions about how those kids should be treated, for example. In other cases, they really focus on accessibility. You can text me whenever you want, you can come see me whenever you want. So yeah, I think as you see a lot of high variance and just like what parents and kids want, you see a lot of the market also respond to that.
If you step back even broader than just peds, it seems like a growing set of conversations around retail healthcare, consumer paying for more healthcare services, adult or peds, just this shift in perhaps the business model of certain types of healthcare services offered. Are you seeing that? And like, what's your take on that?
Anyone who feels undervalued by the current system will immediately look to cash pay, for example, as like a totally alternate route, right? Like primary care has now been doing this for a little bit, but
That's straight cash pay. But what about like, are there hybrid models you're seeing?
yeah, I mean, you could look at the government as another example where a lot of the new CMMI programs are very different in how they think about payments, right? Whether it's the access model, which thinks payments more on an outcomes basis, but also specifically sets a reimbursement rate that's so low that you really can't participate in the model without using tech to a very advanced degree, right? Or you see, they have these like the Elevate model where you basically are getting paid to experiment with some of these more maybe holistic medicine, functional health interventions that pay
Right.
for things that live outside maybe regular CPT codes, right? So there's definitely different payment models along those lines. And then you see, for example, employers, which look like have much more flexibility in what they can cover, how they structure their payments, all this kind of stuff, because they're governed by a totally different set of regulations that regular health insurance are. And so they get more flexibility and they can do different things like direct contracts, or they can pay like per employee per month with some quality bonuses and all this kind of
Sure.
stuff. You need to have a layer that can administer that, which is its own sort of like separate problem. But employers also can be more flexible in how they think about contracting.
Yeah. Are you thinking that On the employer side of things, are you seeing anything around benefits extending where kids and families would benefit?
Yeah, I mean, the big one is obviously cell and gene therapies, which like are pediatrics and rare diseases. And if you look at $1 million claims that stop loss typically has to cover in the employer side of things, like a large chunk of $1 million plus claims tend to come from kids with rare diseases or cancers. This is one of those things where it's like, I think societally, we sort of all agree that, like, yes, paying to cure kids of incurable diseases feels like a good way to spend money, but there exists a coordination problem of who exactly should be paying for that, right?
Yeah.
So no one wants to pay the $1 million upfront cost for a drug, especially if the person's going to churn soon after that because they switch employers or whatever. They're on Medicaid and then they get a job that they're not on Medicaid anymore, same thing, right? So I think there's a lot of stuff in that area and sort of how do you act as a coordination mechanism between a lot of different payers who all are incentivized for, this person to be cured with this very expensive disease, but no one wants to sort of like own the full burden themselves, right?
Yeah.
That can be carve outs, that can be cell and gene therapy, Medicaid models, stuff like that. So there's definitely a lot in that space too. And I think that's where a lot of the focus, especially for employers, is right now.
So on the provider side, we saw a bit of lightning in a bottle with AI scribes for documentation optimization. What do you think the next big use case is going to be as it relates to particularly generative AI and clinical workflows?
Well, I mean, for one, I think the like scribe, clinical decision support, and literature review trifecta will sort of and revenue cycle management as like the four sort of pillars will all slowly start converging, right? Like you already sort of seeing this with a lot of the vendors are all sort of like fighting for that same space because they all kind of relate to each other. So then there's a question of like how much better do you have to be at any given feature than the existing incumbent? How much, for example, sway do physicians have when it comes to high demands for a certain product that they really prefer versus the other parts of those pillars that maybe the like admin cares more about, right? So that tension will pop up also. So, I think inevitably that's gonna happen. And, I do think the thing that I am interested in is sort of there's twofold really, or maybe three things, I guess. One is use of agents in patient facing workflows, right? The topic du jour right now is like Doctronic doing these kind of like autonomous prescribing for medication refills. You can imagine all of the different sort of other things that agents can probably do as well as physicians at this point. Like lab ordering is another good example. Like maybe we should just have people get their labs done before the visit, right? If it's something that they're going to need anyway. So, where can the agents sort of start performing quite well is one. The second is sort of what do net new practice workflows look like, especially for something like brick and mortar? The reality is twofold. One is like we need to get physicians to have larger patient panels in some capacity if we want to meet the healthcare demands of an aging population and all this kind of stuff. And so,
Yeah.
there has to be some line of sight into how do we go to like one doc, 10,000 patient panels. There's different ways you can achieve that, right? Like you can have people already do it today with like extenders, for example, that work underneath a license. You can imagine a world though where AI agents and all this kind of stuff also help you sort of support more people. But then the question is like, what happens when they need to go somewhere, right? And I think actually very different workflows have to be done that can make the in-person experience more valuable to everyone. For example, patient intake forms that are like much smarter and more dynamic and actually like route people to lower acuity settings if that's the thing that they need instead of forcing them to commit. There's also slightly more controversial ones, which is like, what does ambient listening for everything kind of look like for a patient visit if that can actually reduce documentation and also get more sort of info by recording the visit video wise too, not just audio.
Yep.
So there's versions of that too, but requires like a very different rethink of how we do visits basically.
So are you thinking that there could be for primary care or urgent care some sort of digital first?
Yeah, Yeah, I mean, like, think about it this way, right? Like, think about the variance of people that come in through the doors of a given practice. They all have extremely different needs. Some of them don't want to be there, and some of them really want to be there. Even for myself, like, I'm trying to schedule my PCB visit right now. It is a 4 month wait to do it. I
Yeah.
really just need labs, to be totally honest, and
Yeah.
maybe like a check of my current like medication history.
Yeah.
But unfortunately, in order to do that, I have to go to an in-person visit, which
Yeah.
feels a little bit like overkill, right? Maybe we do that. And if something is out of whack, I come in instead. But rather than having like, let's do the full whole shebang there,
Yeah.
why should I kind of like take up someone else's time that actually really wants the doctor to see them for much longer, right?
Yeah.
And this comes down to how we think about reimbursement, how we think about CPT codes requiring like specific things that happen before you can get paid. Like, I think the reality is that if you are building AI native workflows, you also naturally have to have a different payment model attached to that in order for it to work, right? So either significantly cheaper visits. I mean, even like Doctronic, I think if I remember correctly, it's like a $4 visit, right? That
Yeah.
is an order of magnitude cheaper than what like even a copay would be, right? A
Totally.
lot of these things. Or on the flip side, like if you were thinking more about like a value-based care arrangement or something like that, where hey, we can actually like we're under a capitated arrangement and we'll control the costs underneath that, and part of that will be one clinician and maybe managing a much larger pool of people, right? And
Mhm.
that is sort of what the access model is in some ways, right? And it's like, hey, maybe we don't need to like really have handholding with everybody, but like we do need someone to just like monitor these patients, make sure they're taking their statin and all this kind of stuff. And so that's like a different way to think about it.
Yeah. Is there anything you're seeing in the lab space?
I think labs are a slightly more complicated workflow relative to something like prescribing. Not by a lot, but still like marginally more. And I think a little bit of it is like we need more sandboxes to actually test this kind of stuff out. I think there's not a ton of pushback in terms of like the class of medications that are requiring refills that can be
Yeah.
automated. Like, most people, I think, look at that list and they think it's pretty common sense. Labs is a little bit more complicated. And you see this, by the way, for all the debates happening with like catch pay labs that you can get yourself, right? Like getting a full lab panel every 3 months and all this kind of stuff. Like there's a little bit more divergence and like, hey, what labs should a person be able to order
Right.
versus, hey, a person has gotten this medication for like the last 5 years. Like, do we really need to like see them to like keep them on it kind of thing?
Yeah. It's a good point.
So I think it'll happen. I think that is like the next level up of like for on the prescribing side of things. It'll probably be like refills, net new prescribing of meds that in a lower category, and then probably labs. And then, you can keep going off of there, like maybe ordering imaging or however, you want, how far up you want to go.
Last question. Let's say it's a year from now. What are the things we're talking about? What are the questions I'm asking you at that point?
I think there's a few things. I think that for one, I do think that the capabilities of these AI models have gotten so good. And you can already see, even in the last 3 months, how much better they've gotten. That I think that there's just going to be a huge tension between like patients being able to access these tools to do a lot of really interesting things and then hitting the health system, which has no access to these tools. And what basically patients kind of like fighting with their providers about this, frankly.
Yeah.
Like, hey, I trust the AI more, actually. Like, I think that inflection point is sort of already happening, is that there are a lot of people who I think, frankly, trust AI more than their doctors for certain things. And I think that might actually
Well, or
expand.
even if it could be a trust more, but it could also just be a time. So within that 4 month window that you're trying to see your PCP, you could easily engage in AI to get some answer, whereas in 4 months you're getting nothing from a traditional healthcare experience, right? So it could be more versus less trust, but it could
Yeah.
also just be access. I'm getting something. It may not be perfect, but it's better perhaps than literally waiting and getting nothing out of a health system that is just waiting for you to come in, and then they'll give you answers. And even maybe then they won't give you, they may take a few more weeks for you to get answers even after that 4 month visit, right? So I think time to answers, I mean, for a lot of people, healthcare is about getting answers and then getting treatment. Time to answers and treatment, I think, is a metric that a lot of consumers have as they think about who they select for healthcare,
sometimes building trust is a function of spending more time with them. So like if I know what I have, I kind of want to get it done as quickly as possible, right? Like
Yep.
if I know I have pink eye, I can diagnose that myself.
Right.
Versus if I'm like, there's a systemic thing that I'm not quite feeling, or, I have a complex disease with like very high variance in options and like want
Yep.
to talk to someone about it, very different way you build trust that way versus someone who knows what they have. And, for what it's worth, I think the battle will be a little bit as like the things that you're able to probably self-diagnose with a little bit more certainty is probably going to get higher on the consumer side as the models get better. And so therefore, like then the middle becomes a little weirder, right? Where you're like, okay, I've been doing this and I actually feel quite certain that I have this GI issue that Claude is telling me that I have. And I'm coming in with like a certain level of confidence about that situation. Also, by the way, I have dumped my entire record into Claude to help figure that out.
Yeah.
Now with the interoperability stuff actually sort of like getting some traction, like I can pull my records into ChatGPT today and like, get a lot more context and give more data and get more answers that maybe other docs miss because they only have 15 minutes to like think about things, right? So
The piece that very few people are talking about that I'm excited about is prevention. I think that historically our entire system is based on you have a problem, you go see somebody, they take care of it. And now we have too many problems, and not enough people to take care of them. And so the access issue is even exacerbated that, right? But we all know that if you just take better care of your health, you have less problems, which then helps. I think if constructed properly with the right information that people can trust, we can really push and enable people to get, to better prevent terrible things happening with kids or adults or whatever the case may be, so that, we
well,
can
you need
reduce
that.
the
You
amount.
need a new payment model. That's the problem. There is no payment model for that, and so
Yeah, it's true.
that brings it full circle.
Brings it full circle. All right. Thanks again for jumping on the show. It's always fun
Sure.
talking to you and hearing about all the things you're seeing, and looking forward to talking in a year and seeing
Yeah,
you were right.
we can do a scorecard for sure.
All right. Thank you for joining us for your dose of optimism. Make sure to check out our show notes to get more information about our guests and the work they're doing. Visit our podcast page on the KidsX website to join our podcast community and to learn more about pediatric innovation. Thank you to our sponsors and to our presenting partner, KidsX. Please subscribe wherever you get your podcasts, and remember, it takes a village to make sure our kids grow into healthy adults. So volunteer at your local library, help out at the community center, and if you're so inspired, donate to your local children's hospital. All right, see you next time. The content, views, opinions, and information presented on this podcast do not reflect the views of Children's Hospital Los Angeles or of the sponsors of the podcast.